Stefania and I will be talking about the cross-sectional work package that we've recently completed within a wider body of research activities that we've been leading on over the last almost 2 years with this project. What I will do is, just as a reminder, this session is being recorded for the purpose of making a copy of the recording available on our website. We do only record the presentation section of the Lunch and Learn session, so not the Q&A at the end. So I'd ask everyone just to turn off your microphones. I'm going to turn off my my camera to stabilize my Wi-Fi because I'm working from home today. Alrighty, so just by way of ground, so next slide, Stefania. So as I mentioned, we received some funding from NIHR to do some exploratory work, specifically looking at whether there is a need to provide some additional work support for people with physical long-term health conditions to either remain in work or return to work. So just by way of background, we know that around 30% of the working age population in the UK currently live with a chronic long-term health condition. We also know that these patients often struggle to maintain their capacity to work, often due to their health conditions, but also due to other kind of related issues as well. We also know that specifically with regard to certain types of physical long-term health conditions, advances in medical treatments, specifically with regards to disease-modifying treatments, if you like, have really revolutionized the capacity for people to return to, I guess, normal functioning. And when we talk about normal functioning, what we're talking specifically about is also their capacity to return to work and in some cases get back into the workplace for the first time, if you like. So we thought it was important for us to do some exploratory work, really to look at the work histories of people with specific physical long-term health conditions, to understand their capacity to work in relation to these conditions, and also, as I mentioned, to understand whether there is a need to develop a specific work participation intervention. So we know that previous research has been quite limited looking at disease-modifying treatments with regard to work participation, and the earlier work package as part of this research study looked specifically at a scoping review activity. So looking at the existing evidence base around work participation for patients with specific long-term health conditions. For the purpose of this research study, we were particularly interested in patients with cystic fibrosis, sickle cell disorder, severe asthma, and inflammatory bowel disease. And I won't go into too much detail about that work package with regard to the scoping review, but I think just to kind of point out that there were only very few studies which have looked at work participation among these particular patient groups. So it really did point to the potential need for us to give thought to a new novel work participation intervention. So for this particular work package, so this is the cross-sectional survey, the study objective was to establish whether people with one of the 4 physical long-term health conditions would benefit from an intervention, and also to think about what that intervention might look like in practice and how best to implement the intervention and in what context. This cross-sectional study also, sorry, Stefania, just go back to the previous one. Also wanted to specifically collect some data to enable us to build and test this intervention as well. Okay, next slide. So, as I mentioned, this piece of research comprised uh, several different work packages. So, the scoping review activity, which has now been completed. We've also just recently completed the cross-sectional survey, and embedded within that has been some qualitative work as well, really to understand in detail some of the work histories of patients with these physical long-term health conditions, and also to understand what type of support they would find most useful. Next slide. Okay, so the aims of the cross-sectional survey was to collect data, as I mentioned before, to enable us to design the intervention, to understand the level of work, the current level of work participation among these patients, and to scope out their desire to modify their work participation. And when we talk about modify, what we're thinking about here from the outset was just thinking about for some of these patients, they may never have worked before. They may have a desire to get into the workplace. For other people, it might be a case of supporting them to maintain their current capacity to work with appropriate adjustments in place. And in some regards, there might also be a capacity for us to support people to increase the number of hours that they work, for instance. Okay, next slide. So as I mentioned, we have specifically focused in on 4 specific long-term health conditions, and for patients who have recently been prescribed these disease-modifying treatments. We chose these 4 specific conditions for a number of reasons, but principally because if you think about cystic fibrosis and sickle cell disease, these are 2 conditions that often start very early on in a person's life, whereas the other 2 conditions, severe asthma and inflammatory bowel disease, often arise later on. So after people have gone through education and training, they may have been able to establish themselves in careers or jobs, and then suddenly find themselves experiencing these specific conditions. So it was important for us to kind of just track the trajectory across different disease types, thinking about the early onset versus the later onset of the conditions. We also specifically wanted to look at different contexts in which we could potentially roll out an intervention. And looking at the previous research, as many of you in the meeting today will appreciate, a lot of researchers looked at work interventions within primary care settings, but little work has looked at the delivery of these type of interventions through secondary care settings. And we think that there possibly is the capacity to roll out an intervention and to align it around the time of when patients are prescribed these disease-modifying treatments. And this is certainly something that we've been exploring within the qualitative work. Next slide, Stefania. So the inclusion criteria for this cross-sectional study was a confirmed diagnosis of one of the 4 physical long-term health conditions. They needed to be in receipt of treatment from one of our participating centres that Stefania will discuss shortly. We're specifically interested in people of working age, and we took somewhat of a restricted view here. So people aged between 21 and 65 years of age, notwithstanding that people sometimes enter the workplace earlier than 21 years and certainly remain in the workplace beyond the 65 years. But we were particularly interested in this age cohort for the purpose of this study. Thinking about the initiation of these disease-modifying therapies. So we were again thinking about the previous 36 months. And again, we were interested in people with a diverse range of different work histories. So people who may have been in the workplace for quite some time versus people who have never worked, if you like. So we didn't put any restrictions on the employment status as an inclusion criterion. So I'm going to hand over now to Stefania, who's going to walk us through the data collected, and then we'll pick up some discussion at the end, just to think about some of the practical implications from these findings. So over to you, Stefania.
Okay. Thank you, Vaughan. So yes, I'm going to show you the data that we collected. So I'm going to start with the flow chart showing how many people we screened for eligibility. And then we had to exclude quite a few because they were ineligible according to the inclusion criteria that we've seen in the previous slide. Some people were eligible but did not provide consent, and they were excluded. And then an additional 29 consented, so were formally enrolled in the study, but they did not complete any part of the main survey, so they are not going to feature in the tables. So we have 267 participants that have completed the main survey, and I'm going to show you now what they told us about. So first of all, yes, just to show you the different numbers of people that we have recruited in the different sites here. In the first column, these are all the secondary care centers, and the recruitment was ongoing for 11 months, April 25 to March 26. And you can see that for some conditions we exceeded the target of recruitment, cystic fibrosis, for example. Some conditions where we struggle a little bit more, for example, IBD, we didn't reach the target. So this is 267 people, and you can see here that data have been stratified by condition. So the biggest group being cystic fibrosis and severe asthma. So some demographics of this sample. You can see that there is a good balance between genders here, and in terms of age, some groups like cystic fibrosis and severe asthma tend to be slightly older compared to the other two groups. And the ethnicity distribution is not surprising. I think this is one of the reasons why we chose those specific conditions. So cystic fibrosis tend to be more common among people of white ethnicity, while sickle cell disorder is more common among people with Black heritage. And you can see that the proportion of people with university degree or higher is quite high, especially among sickle cell and IBD, so quite a potentially slightly biased cohort. Then we looked at things like quality of life, depression, and anxiety using these validated tools. And the first one, the quality of life measures, is a composite score that ranges between 0 and 1, 1 being the best quality of life. So it is pretty good, I would say. However, the prevalence of depression so at least moderate depression and moderate anxiety is quite high, especially depression. And we've checked the literature about depression and anxiety among this population, and these prevalence rates seem to be in line with what expected with this population, so really high. And then we also looked at the prevalence of different symptoms, and you can see that pretty much many symptoms are very common. Pain, fatigue and tiredness, and difficulty sleeping are very prevalent across all the conditions. Then we looked at employment histories. So in here, we are looking at people that are in work at the time of completing the survey. And you can see that this is quite a high proportion of the whole sample, especially high among IBD participants and cystic fibrosis. And if people are in work, they tend to be employed as opposed to self-employed, and tend to be working full-time hours. And then we used another validated tool, the WPAI, score that measures the amount of impairment that is caused by the condition, the health condition, and affects the person either in work or outside of work. So it's these numbers are percentages. So you can see that the worst kind of health condition in terms of work impairment is the sickle cell disorder patients that they have 11% of absenteeism, so sickness absence, quite a lot of presenteeism. This means that they are in work, but they are not 100% in terms of what they can do at work. And overall, they also report quite high work impairment and also activity impairment, that is activity outside of work. And here we're looking at the remaining sample, people not in work at the time of the survey. And here we've asked them to report the reasons why they were not in work, and they could tick several boxes. But you can see that the first line here, my health prevents me from working, shows that the majority of the sample says that they are not working because of their health. And also quite a few people, especially in some conditions, are unable to find a suitable job, while pretty much nobody says that they do not want to work. So there seems to be an interest in working, but they are not able to find a suitable job for them. And not many are currently looking for work. However, the majority have been working at some point in the past. And here, this last couple of lines show that although they've been working in the past, most people have worked quite a long time before completing the service. So they've been out of work for several years. And finally, this is a very important slide about where we ask everybody, workers and non-workers, whether they would like to maintain the hours that they're working, increase or decrease. And there are some differences, I guess, across conditions. So if you look at severe asthma and sickle cell disorder people, these main two columns, it's the minority that would like to maintain their working hours. So the 60% would like to change. However, most of them would actually like to decrease their working hours. The proportion that overall would like to increase the working hours is around 13-20%. So below the other. If they want to increase the working hours, we ask them how many additional hours they would like, and we can see that people that would like to increase would actually increase by a considerable amount. However, the last line here shows the self-perceive, their self-efficacy in the ability to return to work. And not so many people score high. So this is not so many people feel that they are actually capable to fully return to work to full strength. So a bit of discussion about what we found. Clearly, there was quite a lot of work-related challenges, absenteeism, and poor workability, especially among people with sickle cell disorder. And there was some interest in increasing work participation. However, we saw also a considerable amount of people that would like to decrease the working hours in the future. So some strengths and limitations of our study. Clearly, a great strength is that it's the first descriptive profile in the UK of people suffering from this range of long-term health condition and taking DMTs. And also we had quite a broad range of diseases, while most of the previous studies, I believe, focused more on musculoskeletal issues. We also have quite a wide geographic spread of all the secondary care centers where we recruited patients. And also this clearly another good strength is that it's a mixed method study. We combined this quantitative survey with a qualitative project. Limitations, we've seen that the sample might not be representative of the general population, especially there is quite a high prevalence of people with a high level of education. So we need to be careful if we want to generalize the findings. And also we experienced quite a few challenges with recruitment, especially, and we haven't reached the target, especially with IBD patients. So what we're going to do next, so as I said, there is a qualitative part of the study, then we're waiting for the team to process those data. And also we have a health economics part of the study. Another member of the team is going to perform those analyses about the acceptability of this additional part of the questionnaire and the costs associated with use of different kind of health centers. There are some decisions to be made by the team, so we need to meet and decide whether indeed there is merit in developing this intervention for people to increase the facilitator working, going back to work, and also what exactly that intervention would be like. And again, quite a lot of work still to be done to decide what's the best study design and all the details about the new intervention. And also whether we need to decide whether we should focus on the current physical long-term conditions or different ones, or maybe just a subsample of the ones that we've looked at. And we will keep getting the contribution from the PPI, the input from the PPI group to inform our decisions going forward. And very importantly, all this work is really, really important at the national level because of the current high levels of economic inactivity and government trying to encourage people to go back to work, and especially the huge gap in employment between people with a health condition and people without. And this is the acknowledgement to the whole study team here. And yes, now we are ready to take any question.
Thank you very much, Stefania. Okay, so I'll open it up for any questions or comments from the wider group. I'm conscious. Sorry, Joe, go on.
So I thank you so much to both of you for presenting it.